Action.
Awesome. So welcome to the gastrointestinal mega quiz series. Today we're going to be going through all things gastro. This is a very, very big set of organs and conditions to cover. So you might understand that we probably won't be able to go through every single question, but we'll try our best. Some of these questions we've also dialed down in terms of how difficult they are, because we've gotten a few people saying, these questions are really, really tough. Which is obviously a good revision tool, but we also want to make sure we try and get through as many questions as possible and foster as much discussion in these Zooms as we possibly can. So hopefully you find that that change is good. If not, again, happy to hear any feedback. So let's get started. Question 1. Have a read, and I'll kind of, I guess I'll read through this with you for the first few questions, and then I'll stop because my voice will get very annoying. So you've got a 45-year-old male. He's come to the ED with severe epigastric pain that's radiating to the back. He also reports a history of heavy alcohol intake and a recent episodes of binge drinking. Lab tests show elevated serum amylase and lipase. Abdominal CT shows inflammation, edema of the pancreas, and a fluid collection around the pancreas, and his vitals are otherwise normal. So what do you think is the best sort of first-line therapy for this patient? Keep your questions on, keep your answers on hold for a second. I'll give everyone maybe 15, 20 seconds to have a think, and then you can post it in the chat. Okay, cool. Hopefully you had a chance to think about this. Feel free to write your answers in the chat now, and we'll have a look at what you guys think. And remember that these are all sort of like two-part questions. So the first part is usually to think about what condition is causing this patient's presentation, but more so than that, it's about management investigations that are adjunct to what you think. So oftentimes it's good to have an idea of what the condition is, but you should also have a really good understanding of things a bit more than just being able to identify the condition. So a lot of people have posted in the chat D, which is correct. So in this case, what do we think they have? Can someone write in the chat? Yeah, fantastic. And so people are saying pancreatitis. Specifically, we think it's an acute pancreatitis, or it can be an acute on chronic pancreatitis. We're not really sure. They've got a history of alcohol intake, which is one of the big risk factors alongside gallstones. And you might remember that I get smashed mnemonic, which is quite good to remember the more, well, not the more common causes, but at least a few of the common ones and a few of the really strange ones, which is a good idea to have in the back of your mind. In this case, there's no real like definitive management for acute pancreatitis. It's mostly supportive. So IV fluids and analgesia is the way to go. If his vitals were kind of off kilter and we were wondering whether he's hemodynamically unstable, that's a different story. And we might want to go to surgical exploration and figure out what's going on. But for the most part, for acute pancreatitis, you want to optimize their fluid balance and provide them with pain relief as much as you can. Once the episode is done, then you can identify the causes and then correct those to prevent future episodes. So in terms of fasting, so like oral rehydration, you generally want to avoid oral rehydration. You generally avoid in patients who come in with like acute cases of pancreatitis, and the reason why you do that is because you don't want them to aspirate if you need to accidentally, or if you need to urgently take them to theater for some sort of like surgical procedure. For example, if the acute pancreatitis becomes necrotic or infected, you will have no choice but to take them to theater. And so you want to try and avoid oral rehydration. Fasting is okay, but the only problem with that is that like in and of itself, that response is not the best answer. You still want to optimize their IV fluids, and it has no mention of pain relief, which is one of the pillars of acute pancreatitis management. So A is kind of okay, but it's more geared towards, okay, we really need to get this person into theater, which is why we're doing this. Whereas right now, we're not worried about taking them to theater. We're more worried about optimizing their fluid balance and giving them pain relief. So hopefully that makes sense to whoever asked that question. But the answer here is supposed to be D. Okay, here's the next question. We've got a 25-year-old man presenting to the ED with right lower quadrant abdominal pain. It started as periumbilical discomfort, and it's progressively localized to the right iliac fossa over the past 12 hours. He has anorexia, nausea, and a low-grade fever. On exam, there is tenderness and guarding in the right lower quadrant, and Rovsing's sign is positive. Have a think about what Rovsing's sign is and what it's useful for. The patient's leukocyte count is elevated. An abdominal ultrasound shows a non-compressible tubular structure with increased blood flow in the right lower quadrant. So again, thinking about what that actually means. So what is the most appropriate next step in this patient's management? Have a think for a few seconds, and then I'll ask you to write your answers in the chat. Okay, hopefully everyone's had a chance to think. Post your answers in the chat now. What do you think is the best management for this patient? Yeah, fantastic. So everyone is on the right track. We're all thinking A, which is correct. There's no real reason to not recommend appendectomy in a patient with very obvious signs of appendicitis. And just remembering the signs, like Rovsing sign is when you press in the left lower quadrant, and that leads to irritation on the right-hand side. So it's just a sign of generalized peritonitis, which is not uncommon with appendicitis. In terms of the other options, IV antibiotics might be all right, if not for the fact that it said only, which kind of tells us that in this case, they're only giving IV antibiotics and not trying to get the appendix out. Nowadays, they're actually there's a lot of research into whether appendicitis can be managed more supportively instead of with surgery, but there's not enough evidence to support it in kind of the long term and in the public space. For now, appendectomy is the gold standard, and it makes sense for an acutely inflamed appendix. Okay, I've got a few questions. So about wording, does next step imply definitive management or what you do first? And I think I've got a few questions. Yeah, so given that it says next step, would it be? Yeah, so you're all right. So generally speaking, next step is the next thing you would do, not just the definitive management. In this case, it just means that both of them coincide. Like as soon as you see this patient, the main thing you're going to do is to take them, prepare them for surgery. The reason why B is wrong is because it's implying that you're just going to give them IV antibiotics and stop there, and that's it, which is not really supposed to be what you do, because there is a risk that this is going to turn out to be it's going to become gangrenous and it's just going to perforate or become worse. And yes, so the ultrasound and the clinical picture in this case is enough to diagnose appendicitis. You don't need anything else aside from that. You've done some blood tests and stuff which indicate infection as well, and your clinical examination is pretty supportive of it. Cool. Well done, everyone. Yeah, so if option B didn't say only, it would probably be more correct as the first line management, and then you would take them to appendectomy. But that wouldn't be a question because that would just be unnecessarily confusing. So that's why I put an only there. All right, we'll move on to the next one. So a 26-year-old woman returns from a vacation in Thailand with watery diarrhea symptoms, abdominal pain, and nausea, and vomiting. She denies any blood in her stool, myalgia, or arthralgia. She's diagnosed with gastro and provided with oral rehydration solution, but doesn't improve after a few days. A stool sample is sent off.
Yeah, this is one of mine, I think.
Awesome. Also, I just got someone asking if you would give analgesia before surgery. In this case, you probably would. So if you think about your pre-op preparation, you're thinking about IV antibiotics, pain medications, anti-nausea medications, that sort of stuff, like IV fluids, 2 large bore cannulae, that sort of thing. The question in this case is more hinting towards the actual definitive and first line management. When you're in an OSCE, I think you can say those things just to tick off the boxes of what pre-op management looks like. But absolutely.
All right. Hopefully you guys have had a chance to think about that. So I'll get you guys to chuck your answers in the chat now for this one. Okay. All right, I'm seeing a good amount of B. So that's absolutely correct. So with gastro, really, we've got a bunch of different causes we want to think about. You can get atypical bacteria, certainly, but E. coli is a really big potential cause. And then within the viral area, we typically have two main viruses that we think about. So when we're triaging these, we want to think, okay, well, what sort of gastro are we dealing with? Because that will help guide our management. So the main thing, I mean, sort of the first step that we want to think about is, okay, is this a bacterial or a viral gastroenteritis? Because in every case, we want to be doing rehydration, we want to be giving supportive treatment. But in terms of what will actually cure it, in bacterial gastroenteritis, you're more likely to actually want to get them on antis, whereas with viral gastro, most of the time it's a self-resolving thing. So you're just like, okay, here's some rehydration, go home, come back if it doesn't get better. So in this case, she's the person who's come back because it hadn't got better. And the fact that it hasn't self-resolved is more suggestive of a bacterial gastroenteritis. And then the same thing there so she hasn't had any muscle pain, she hasn't had any issues with her joints or her muscles, sorry. And that will then mean that we are more likely to think about a bacterial gastroenteritis. So within our different types of E. coli, there are a couple buzzwordy things, which are some of the useful ones in actually figuring out which type we're dealing with. Enterohemorrhagic one is a very nice one because it's in the name, and it's very highly associated with blood in the stool. With your enterotoxigenic and enteropathogenic, that has more to do with, like, enteropathogenic is pretty useless as a name because they're all pathogenic. But what is useful about that one is that there's a P and it abbreviates to EPEC, and it's usually the one associated with kids. So peds usually helpful. There are some weird ones. You can get like EA. I actually can't remember what A stands for in that one. That one's associated with South America, so you're not super likely to run into it here. The one we're dealing with here, though, enterotoxigenic E. coli, T for travel. So the buzzword for this one, which we have in this case, it's not Thailand, but it is overseas travel, that we're likely to have someone come back from and then pick it up. And it's a decent one to also find just in the community. So you're not ruling it out. If someone comes from the community, you're not saying, okay, well, you kind of enterotoxigenic because you haven't traveled recently. So of these, your ETEC and your EHEC are the ones that you're more likely to try and put someone on antis for. To my knowledge, you usually, the three that you're thinking of are ciprofloxacin, azithromycin, or rifamycin. For this one. If you are dealing with like EPEC or EAEC, I actually don't know about EAEC, but EPEC, I'm fairly sure that you are not too concerned about antis until it gets worse. But with ETEC, if you identify as ETEC in the first instance, so like they've come in, they haven't come back, but you know it's ETEC, you get a stool culture with it back or something like that, start them at antis, because that's less likely to self-resolve, and so you're actually going to get somewhere with it. Perfect. Right, I've rambled on for long enough, and watch for hemolytic uremic syndrome in this one because that's a semi-common complication and it can be quite bad. Someone asked to repeat the antis. I can actually put them in the chat, but it's Cipro, Azithro, and rifamycin. So I'll write those in.
Fantastic.
Next question, I think.
There's going to be plenty of gastro buzzwords to go around in this set of slides, so we'll definitely come across more of these agents when we do those. For the most part, though, we're going to come back away from gastro and back to some of the more acute presentations of the abdomen. So 65-year-old male, sudden onset crampy stomach pain, bloody diarrhea after having a recent cardiovascular surgery. Exam has shown tenderness in the left lower quadrant. Lab tests show an elevated white blood cell count and metabolic acidosis. And we also get this apparent thumbprinting sign on abdominal CT in the bowel wall. What do you think is the most likely diagnosis with this presentation? So I'll let you just spam the chat now with your answers because I think a lot of this is quite buzzwordy. So once you're ready, just feel free to paste it in the chat. I've got a few coming in already, which is good. I'll just give you a few more seconds. Yeah, brilliant. So we're thinking in this case, ischemic colitis. There's one blood test on, I said lab tests, but there's one blood test that I haven't actually included, which is quite good. Like if you're in an OSCE and you think someone has ischemic colitis, or even if there's abdominal pain very acutely, there's one thing you would order on your blood gases that I haven't put in there. Yeah, exactly. So that's lactate. And that's partly the reason why they have a metabolic acidosis, is because of that increase in the lactate. That indicates some sort of organ damage, which in this case is bowel damage. So you got your classic picture of bloody diarrhea, stomach pain, as well as the recent cardiovascular surgery, which could mean anything. It might not be relevant at all, but generally speaking, someone with cardiovascular risk factors is more likely to have ischemic colitis, either because of a clot being thrown off or because of reduced blood flow, and therefore it become ischemic. Thumbprinting sign in and of itself is not a buzzword or pathognomonic for ischemic colitis. It's actually just a generalized sign for colitis or inflammation. In fact, there's even a thumbprinting sign that you get in the epiglottis, which is a sign of, like a throat infection in kids. So thumbprinting is very general, but it just tells you that some sort of colitis is happening. In this case, not very helpful because you've got 3 options or 4 options that are to do with inflammation of the bowel. But I guess it just helps you in your workup. That's a really good question. So thumbprinting is definitely not pathognomonic. Fantastic. Well done, everyone. Let's go to the next question. Here we've got a 52-year-old woman who's presented to her doctor in distress because she's feeling tired all the time. She's also recently found that her stools are less firm, although she hasn't noticed any mucus or blood in them. And she's noticed that her pants fit more loosely than they once did, although she's not really too concerned. On examination, her sclera are pale, but she's otherwise well, with no abdominal findings. A DRE is not remarkable. Her doctor orders blood tests to investigate her fatigue, which are all normal, except in this case for a low hemoglobin, low serum iron, and an elevated TIBC. So which of the following do you think is the most appropriate next step for this patient? Again, just to avoid confusion, and I can see why there might be some confusion with regards to the wording, assume that only one of these things will be done, not kind of like, oh, we'll do one of them and then we'll do the next thing. So what would be the most appropriate thing in the next step? But think about the other stuff not having happened yet or immediately, if that makes sense. Okay. Cool. So feel free to post your answers in the chat now. All right, fantastic. So I've gotten most people saying B, which is probably where I would go as well. The main thing you're worried about in an elderly patient who has signs of anemia as well as weight loss is the fact that they might have a colorectal cancer that's been slowly growing and no one's really been aware that it's there. And they may have missed their stool screening tests. So they might not have been able to actually detect the blood. And sometimes they just get missed. So occult blood is not always the case. And so in this case, we actually had, I think it was a practice, like we didn't have apexes last year, but we had a practice OSCE in our hospital where we actually did look at a case like this. And essentially the main thing you want to prioritize is getting them ready for a colonoscopy. Yes, you can give them an oral iron replacement and that'll fix the iron deficiency, but it's not really going to do much if the underlying cause is a colorectal cancer. So first you want to investigate all of what the biggest red flags are. And then if you can rule out a colorectal cancer, then it's perfectly fine to say, okay, we'll give you oral iron replacement based on the fact that we think it's mainly just a dietary thing. I know someone in the chat has said D, send for FOBT. That's actually a really good point, and I didn't really think about that. The main thing that I was thinking about for sending the stool sample was to trick you guys into thinking this might be some sort of gastro because of the fact that her stools are less firm. So it might be some sort of dysentery or something. That is a possibility now that I think about it. You could have an FOBT, but the fact that she's already presented to the doctor means that the best thing you can do to be more specific at ruling it out is a colonoscopy, because an FOBT might not be diagnostic. It might be a false positive, it might be a false negative. That's a really good point. It's not something that I had in the back of my mind. Okay, is jaundice from Mets? I didn't actually put anything about jaundice in this. Let me just have a read again. Yeah, no, that's okay. Yeah. So her sclera is pale. That's mainly just anemia. Or I should have said conjunctiva is pale rather than sclera, because sclera is usually where you look at for jaundice, which is probably where you got that confusion from. But if there was jaundice, then yes, you might be worried about Mets, but that's not present at this stage. Cool. All right, let's go to the next question. This one's a bit shorter, thankfully. You've got a 73-year-old gentleman. He presents to the hospital with difficulties in swallowing mainly solids. He hasn't seen his GP in a long time, although on admission, he admits that he has been having some burning chest pain, regurg, and dyspepsia for a while. He's a non-drinker, and he smoked for nearly 20 years before giving it up at 42. He has lost weight, but is otherwise systemically well. What do you think is the most likely diagnosis? So again, have a bit of time to think and run through all the options. And then once you're ready, paste your answers in the chat. Okay, I think I've got a few answers already, and they all seem to be along the right track, but I seem to have trapped a few people with some of the other options, which is great because it shows that you're thinking about all the risk factors that this patient might have for the various conditions that I've listed in the options. The correct answer here is actually D. And the main reason why is I think all of you have probably looked at this and realized that one, they've got difficulties with swallowing, and it's mainly with solids. So it indicates potentially some sort of obstructive cause of the dysphagia. If it was solids and liquids, then you might be thinking this is more of like a neurological problem that's affecting swallowing in general. So that's one thing to think about. The second thing is they've lost weight and they have a lot of risk factors for a tumor that might be growing in their esophagus, including the fact that they have what seems to be some sort of GORD because of the chest pain and regurgitation. And they also have smoked for 20 years. So there's a lot of things going on that might make you think this is an esophageal cancer. But the question is, what type of esophageal cancer is it? And it's more likely to be D because squamous cell carcinoma, you might be thinking that because of the smoking, but the fact that they've stopped at 42, which is, it's more than 30 years since this, from this presentation, means that it's much less likely, and it's less likely to have not been detected for all that time before it finally came back. The esophageal adenocarcinoma is more likely to be a complication of the GORD. So what's happened is they've got GORD that's developed into a Barrett's esophagus, which is just a metaplasia. It's not actually like a dysplasia. It's not yet a cancer. And then you actually have it growing into an adenocarcinoma, which is resulting in the physical blockage. That's why it's not A and not C, which is what a few of you have picked. And that's why the final answer should be D. Could it be Barrett's causing a stricture leading to less appetite, hence weight loss? That's a good question. I'm not sure. Like, I think Barrett's esophagus can cause a stricture with long-term, like chronic damage. I'm just trying to think about what might lead you away from that and towards an esophageal cancer. I think the fact that, I mean, look, what I'll say is I think it's a possibility. But I think what they're like in this question, what I'm trying to get you to think about is just that malignant transformation with the risk factor of the GORD. Although I can't say why it can't be Barrett's causing a stricture. If the option was Barrett's causing a stricture, then I think that would be a possible answer. But Barrett's esophagus by itself, without any other complications, is much less likely.
Yeah. Another thing to notice as well is that the having a stricture doesn't necessarily give you anorexia. So it'll give you difficulty swallowing and potentially painful swallowing, but those are not the same thing as a loss in appetite necessarily. So, you can talk about maybe that's why somebody loses appetite, but that's not really enough on its own.
Exactly. Yeah, so it's a really good thought, and it's great to see you're thinking more laterally. But I think the fact that it's just said Barrett's esophagus as an option is less likely that that's the only thing contributing to their dysphagia at this time. Okay, cool, well done. Next question. Another short one. So a 72-year-old carpenter, he's got a painful, irreducible bulge in the right inguinal region. Patient reports that the bulge has been present for several hours and is associated with nausea and vomiting. On examination, the overlying skin looks red and it's full of edema. The lump itself is also quite tender and hard on palpation. What do you think is the most appropriate initial management for this patient? I should probably do away with this like initial management sort of thing, but in the Monash exams, they do like to differentiate between initial management and kind of like best management or definitive management. That's why I've put it there, but I can understand why it might be quite difficult in terms of wording. So just have a think. What do you think is best for this patient? So first, what do you think this patient has? How bad is it? And secondly, what do you think is the most appropriate response to it? Okay, and once you're ready, once you've read the questions, paste your answers in the chat. Hey, brilliant. Okay, so a lot of you have realized that this is quite a severe presentation. So we're thinking it's some sort of hernia. It's an inguinal hernia. And I guess the main risk factor you could be thinking about here is that they're a carpenter, so probably doing a lot of stressful work, which is increasing abdominal pressure and more likely to lead them to have this sort of thing. Plus, they're 72 years old, so the abdominal wall muscles probably not as strong to hold in the intestines. That's why they might be having this problem in the first place. But in terms of the actual presentation, because it's associated with nausea and vomiting, you might think this is an obstructed hernia. So it might potentially be something that's blocking off the intestine. The fact that it's quite red and edematous might also make you think this is strangulated as well, or at least incarcerated at the minimum. So just know what these words mean. And the fact that this is not just an uncomplicated hernia where you can probably reduce it means that you're not going to be able to just go in and push it back in. The reason why we don't do that, even though you might think, why not? Because you're going to be able to put it back into its compartment, is that if by chance this bit of bowel has already died and you push it back in, you risk that bit of bowel perforating in the next few minutes or hours, and that can lead to sepsis like very quickly, and the patient could die. So you don't want to just perform manual reduction. The fact that you've noted that it's quite red and hot means that it needs to be taken straight to theater so that they can open it up and properly assess whether any parts of the bowel have died yet or not. Similarly, the rest of the options by themselves are not great. They might be temporizing measures, but the definitive thing you need to do, or at least the initial management, is to book that theater and get them straight away for exploration. And a lot of you have gotten that already, which is fantastic. Amazing. Here's the next question. I will not read this one out again. So just have a read. And the question is, which of the following is the most appropriate next step for this patient? I'll give you 30 seconds. Okay, so it's a lot of information, but hopefully you know what's going on and what might be the next best thing to do. So type your answers in the chat when you're ready. Yeah, brilliant. Well done. So everyone is mostly sticking with A here, and that's good because essentially B is there to be a bit of a red herring, and it's really easy to be like super overcautious with these sorts of things. So like you see what looks like an ulcer in the duodenum, and you're thinking, cool, but what if it's cancerous? And you really don't want to miss that, right? But generally speaking, if an ulcer is found in that region rather than being in the stomach itself, it's highly, highly unlikely that it's malignant. Very, very unlikely. So much so that it's not routine for anyone to request a biopsy of it and then let those results then guide therapy. Most of the time, those will be just because of a H. pylori infection, which is indicated by that urea breath test coming back positive. So you don't actually need to also then go out of your way and confirm it again with a stool antigen test. It's only really one or the other. Once that's there, you have enough information to say, cool, this is a simple H. pylori infection. I'm going to start the triple agent eradication therapy, which is ACE. So hopefully you guys remember that mnemonic. I've just got a question. So when should you do a biopsy? That's a really good question. Generally, you would do the biopsy if it's a stomach ulcer, or if this is like a recurrent problem, or if the ulcer, when you're doing endoscopy, looks very abnormal. In this case, because it's well-defined, round, and clean based, there are no signs that this is a malignant ulcer, if that makes sense. So it's actually overcautious and might actually present more risk to the patient to unnecessarily put them through a biopsy. Cool. Didn't he get the triple therapy before? So you would assume that in the past he would have had the infection, gotten the triple therapy, and then that's done, like that's finished. But there's no, like he probably might not, it's not necessary that they would be taking the triple therapy for life, right? It could have been cleared. And so you want to check firstly, are they still on any of those medications? They might still be on the PPI, but you want to put them back on the antibiotics as well, because you need all three of those things to form the triple therapy. So that's a good question. If you fail triple therapy, potentially you might want to do further investigations. Amazing. Well done. Here's the next one. It's a bit of a simpler question. So you got a 4-month-old child brought to the ED. They've got severe vomiting and watery diarrhea. They also look quite lethargic with a temperature of 38.6, so quite high. The parents report that the symptoms started about 2 days ago and that in the preceding week, 2 other kids in the daycare were taken home with a similar sickness. So what do you think is the most appropriate management? Oh, brilliant. I'm already getting answers. So I can see that everyone is on the same track, which is that it's most likely that this patient has a simple viral infection, and in this case, more likely to be like rotavirus, and they've caught it from the daycare, and that's what's causing them to have the severe vomiting and diarrhea. And it looks quite bad, obviously, like you've got a really high temperature, but usually with just a bit of supportive therapy and trying to avoid over management of these sorts of patients, you're able to stabilize them very, very easily. So the main thing you're worried about is that this person is just going to become super, super dehydrated, and you want to avoid that. So oral rehydration where possible. The fact that there's severe vomiting is a bit of a red flag, though. So I just encourage you to think you'd have to kind of take the clinical picture into account and realize that if they're vomiting everything up, you may have to admit them to the hospital and potentially have them have, IV fluids running or nasogastric fluids running. But you want to start with oral and see how that goes. I've got someone asking why it's not bacterial. That's a really good point. Generally speaking, like remember that rotavirus is a clinical diagnosis. You can potentially order stool samples. I've actually seen it done once because they were really unsure. It was an atypical presentation. But generally speaking, it's clinical. And this entire history fits the bill really, really well. If there were other things that made you think, is this patient potentially septic? Then you would be more concerned about potentially like a bacterial problem. But they've got a really strong history, and the fact that they've got like a social background of having kids in the daycare having the same thing makes you really strongly think this is rotavirus and not anything else. Obviously, if again the oral rehydration didn't work, you'd admit them to the hospital and do further investigations. Okay. So the answer here is E. Oh yeah, and some people were asking why it's not D. You can like this is, I guess it's a great time to give the rotavirus vaccine. I think it's given it's given 3 different times, I think, according to the Australian vaccination program, and 4 months is around the time you might get the second one, but someone can confirm that. The reason why you wouldn't do that now is because they're very acutely sick, and if it's an oral rotavirus vaccine, they're more likely to just vomit it up. So it's not going to be helpful. Right now, for the initial management, rehydration is the best course of action. Cool, well done. Here's the next one. 65-year-old progressive dysphagia to solids and liquids, regurgitation of undigested food, and weight loss. His physical exam is unremarkable, and a barium swallow is done, which shows that. What is the most likely diagnosis? So again, feel free to type your answers in the chat. Well done. Getting very enthusiastic C's here, which is correct. Can anyone write in the chat what this is, like what the name for this sign is? It's got an animal association with it. Yeah, it's called the bird's beak sign. So this is what it looks like, and this is the reason why they've called it that. There's some signs that don't look anything like what they say. I think this one is close enough. So it's got that typical appearance at the very end, because of narrowing of the lower esophageal sphincter. You might still be like, it's perfectly fine to still be worried about esophageal cancer, but generally speaking, that's not the location you would have it. You would have that classic kind of like apple core sign somewhere in the middle, and that might make you think, along the lines of cancer. Weight loss is not always cancer, especially if you have a problem with the esophagus. You're going to have some form of weight loss because you're not able to tolerate food. So it's really good that you guys haven't fallen into that trap. In this case, it's achalasia. Cool. Apparently, it's also called rat's tail sign. I haven't heard that one myself, but if it works for you, it works for you. I think that's perfectly fine as well. Awesome. Next question. A 30-year-old female with recurrent episodes of severe crampy abdominal pain. The pain is associated with bloating, flatulence, and alternating constipation and diarrhea. There is no fever or weight loss, and examination is unremarkable. Stool exam doesn't show anything. So what is the most likely diagnosis? And remember, this stem is not like complete, so it won't have everything in it that's required to reach your diagnosis. But you have to try and think about what is the most likely out of all of them. Yeah, great. So it's most likely to be irritable bowel syndrome, so IBS. It's happening kind of infrequently. And there's alternating constipation and diarrhea, which is kind of the main thing pushing you towards it. Most of the other examinations you've done, which I admit are quite limited at this moment, are negative, which means it's probably less likely to be an organic cause. Irritable bowel syndrome doesn't have a cause that we know as of yet, but there seems to be psychogenic components to it, as well as changes in the gut microbiome and that sort of thing. So it's most likely to be the case here. Well done. When would this change from IBS to IBD? Do you mean the stem itself? Because generally speaking, IBS doesn't transition to IBD. They're kind of very separate things. But I guess what would make you think this is more likely to be IBD is if it was not like the alternating picture. So if it was something like just diarrhea and it's got that crampy abdominal pain, it doesn't happen every few weeks. It actually happens a lot more frequently. If it's accompanied by bleeding, and if there is positive tests that the question is giving you. So there's an inflammatory process, you'd expect to see elevations in the inflammatory markers and that sort of thing. But in this case, we haven't been given those, so we're less likely to say that it's IBD. Cool. Fantastic. Well done, everyone. Here's the next one. 22-year-old female presents with chronic recurrent abdominal pain, bloating, and diarrhea. The pain is located in the epigastric region and it's not relieved by defecation, although she has noted that the pain gets worse after eating foods containing wheat. So she has avoided these in her diet for the last 7 months. She also reports a history of unintentional weight loss and tiredness. Given the most likely diagnosis, what do you think the best next step is? Again, have a read of the options carefully. And then once you're ready, post your answers in the chat. So think, what do you think she has? And what do you think we should do? Okay, I've got a mix of responses here. Most of you are on the right track though. So I think all of us know by just reading the history and the fact that it's mainly stimulated by wheat probably tells us that we've got a patient who has celiac disease. So that's really good. But the thing is, what do we do about it? We've actually got one person who was able to get the correct answer here, and I'm really happy with it. But it's a really tricky question. Like it's super, super tough. I just wanted to try and make a question that was quite focused on management and about being very holistic. In this case, the answer is actually D. So you might think that it's A or B because that's the way that you normally achieve your diagnosis of celiac disease. It's positive tissue transglutaminases. It's positive endoscopic small intestinal biopsy. It shows those classic features. But the only problem with that is that this patient has stopped having gluten or they've stopped having wheat, whatever it is, they've stopped having it for 7 months. So the fact that they've stopped having it means you're not going to actually have any of those tests being positive at all. right? What you actually need to do, and it sounds super mean, but you actually need them to start on the gluten again and then do the tests once the symptoms come back. And it's actually a really common thing. Some people will just stop eating it because they realize it's associated with pain. But in order to actually get positive diagnosis and to kind of close the chapter on this and say, this is definitely celiac, we need their intestines to be slightly damaged for us to then get a sample of that and then be able to give the diagnosis. Okay. Yeah, so even the tissue transglutaminases, depending on which IgGs you're looking at, the most commonly ordered IgG, which I'm not going to say yet because there's probably going to be questions on it later on, hint, hint, they can go down. So remember, there's a cutoff for these tissue transglutaminases, right? If you stop having gluten for a long time, they're just going to go down. They'll fall below the diagnostic criteria, and then all of a sudden you can't diagnose it anymore. You still need them to be back on the gluten for them to have that damage happening, for them to generate those IgGs or the IgAs, whatever they are, and for us to be able to detect them and test for them. Does that make sense? So it's a really tricky question, but I just encourage you to think about every single bit of information in the stem is super important. And the fact that I've said that they've stopped eating the gluten or the wheat is not for nothing. Like, it's there for a reason. Okay. Well done. I only learned this year. So if you messed it up, it's totally fine. I wouldn't have known this last year either, but it's a really good fact to know. Brilliant. Here we go. I don't think this is my question. Is Deepak in?
This is one of
Deepak,
mine.
are you here? Okay, cool. Awesome. Take it away, James.
Yeah, no worries. So we've just got an interesting history here, where we have partially some GI symptoms and also some chest pain, our favorite non-differentiated presentation. So have a go. Think about it. Think about what you think might be going on. And then I'll ask for your answers in a little bit. Okie dokie, what are we all thinking? All right, I'm seeing a few answers come through as E, enzyme replacement therapy. Now, some of you said it. I think the others of you are also thinking it, but chronic pancreatitis, basically. So, we can find, we can explain his chest pain, which is I've sort of described in an oblique way, but what it really means is that's radiating to the back. So he's got chest pain radiating to the back. He's got malodorous greasy stools because he's having trouble with exocrine pancreatic secretion. And he's got alcoholic fatty liver. So we've got a picture here of actually it's mixed pathology because he's got alcoholic fatty liver, which is also why he has the jaundice. But he's also got symptoms of chronic pancreatitis. And he's got blood sugar level elevated, which is again because of the pancreatitis. But the question is, what are we going to do about it? So we know he has chronic pancreatitis. We know he has alcoholic fatty liver. But the first line therapy for chronic pancreatitis is not to jump to enzyme replacement therapy. Enzyme replacement therapy is if you fail the first step, which is lifestyle management, which is basically thinking about alcohol and nutrition. Okay. So you have to think, okay, well, number one, chronic pancreatitis is about chronic inflammation. So it's not necessarily, I'm sure, like if you have it for long enough, you're going to get some irreversible damage. But the main disease process is not about but basically like losing pancreatic tissue. It's that we have inflammation, which can be, taken away. And if you think about that, so 3 to 5 standard drinks, it's not huge. There are people who drink more that you'll see in clinic, but it's not small either at all. Like if you had a patient who came in and said, doc, I've got pain radiating to my back and I just had 5 drinks last night, then you think, okay, well, clearly there's an insult here. So what he's doing is he's insulting the pancreas again and again and again. And so, of course, he's got chronic pancreatitis. I'm going to answer a question on the way here because somebody just asked me why his LFT is consistent with alcoholic fatty liver, because he's an alcoholic and he's got alcoholic fatty liver. So he's got both of them. They're both disease processes coming from the alcoholism, right? And the good thing here, and maybe something I'm hinting at with the alcoholic fatty liver, is he's not in irreversible liver disease yet. So he hasn't got cirrhosis, certainly. He's still in the stage where we can get reversible changes that can then go back to normal if we think about alcohol cessation. So if we tell this guy, okay, well, cut off the alcohol, just, send him onto some program. And then if he cuts out the alcohol and he's still got problems, then we can think about enzyme replacement therapy. And with them, we think, okay, well, maybe you do have permanent damage. But we can't really assess if he has permanent damage requiring enzyme replacement if he's currently inflaming his pancreas more, if that makes sense to you guys. Like, you don't know if he needs the enzymes because we've never seen his pancreas without a current sort of flare, right? This is like, he's basically in a constant acute exacerbation of chronic pancreatitis. So if we then take it away and we say, okay, your baseline needs the enzymes, then we put him on enzyme replacement therapy. Cool. Somebody asked, is insufficiency exo and endocrine? Not sure if I fully understand what you mean, but in chronic pancreatitis, you get damage to both the exocrine and the endocrine parts of the pancreas. So you'll get both diabetes symptoms because of the endo side, and you'll get symptoms similar to pancreatic insufficiency in terms of the GI symptoms because the exocrine pancreas isn't working.
Never, ever, ever underestimate the power of lifestyle changes unless it's an acute emergency thing. That's pretty important. Also, I got the funniest question. Will we get a bathroom break? You can go to the bathroom whenever you want. That's the beauty of Zoom. And we won't see what you're doing. We won't hear what you're doing. Totally fine for you to duck off for a bit. I'm going to read the questions out loud anyway, so you'll be able to follow along. Hopefully you're not wearing your headphones all the way through, but if you want to, go for it.
I'm hoping they were joking.
Yeah.
I still get year 12 students in my tutoring class that just unironically ask, can they go to the bathroom? The answer is always yes. It's always yes.
Yeah, always yes. Your health comes first, guys.
Yeah. I think somebody asked me at some point, do you get bathroom breaks on ward grounds? Yes. Like,
Oh yeah.
the team does not want you to pee yourself on ward rounds, okay? If you need to go to the bathroom, like, they're not going to stop you.
Yeah. Cool. Okay, here's the next question. So 66-year-old man arrives at your clinic with on and off epigastric pain and diarrhea on a background of chronic and heavy alcohol use. You suspect that they might have chronic pancreatitis. However, he would not like to have a CT scan performed because of a debilitating fear of loud machines. There are other ways to look for pancreatic or chronic pancreatic insufficiency, though. So which of the following do you think is good for that purpose? Which is the best initial test? Obviously, CT scan is what you really want to go for, but if that's not possible, how else can you support the diagnosis of a chronic pancreatic insufficiency? Awesome. I'm getting mixed responses here, but most of you are putting down E, which is correct. So fecal elastase, not something everyone would have heard of, and that's totally fine. If you know it, you know it. If you don't, that's it's impossible to get. But now that you know, fecal elastase is a really good marker of chronic pancreatic insufficiency. Pancreatic lipase and amylase, not so much. They're actually really good for acute pancreatitis. But once the pancreas has adapted to the insults, those levels are actually usually normal in a patient with chronic pancreatitis. So you will most likely just see normal lipases and amylase. Imaging-wise, abdominal ultrasound is not going to be really helpful. It's not going to show you any specific changes for pancreatic insufficiency. What you're looking for is not a structural thing. It's more of a functional problem. And serum fat-soluble vitamins, again, less likely to be reduced because of the fact that usually in a chronic pancreatic picture, you will have adaptation to these sorts of problems. Fantastic. So I think everyone's on board with that. So just remember, fecal elastase is really, really good for chronic pancreatitis. Not always used because generally patients are okay with having a CT scan done to confirm the diagnosis. Cool. Here's the next question. So a 22-year-old female, this is coming back to something we've done before. 22-year-old female, it's the same thing. So after being restarted on a gluten diet, which is what we were recommending, for a sufficient time period, her doctor orders a few relevant tests. So now it's actually useful for us to get these tests. Which of the following is least likely to be observed given her diagnosis? Also, just while you're answering this question, I've got a few questions about option A in the previous one. So technically, yes, your serum fat soluble vitamins might be low. Most of the time, they're not because it's a chronic picture rather than being acute. They can be low, and that's why you can get replacement. But it's actually not. It's not as specific for a pancreatic problem than fecal elastase is. So you're more likely to order a fecal elastase, which is quite easy. It's just a fecal, like a stool sample, and then they measure the elastase in it. Serum fat soluble vitamins can be ordered as an adjunct, and those two things together are really good for helping you get your diagnosis. But fecal elastase, the point is it's more specific for a pancreas problem. So A is not wrong, E is just better, which is the case for a lot of these questions. Okay, back to this one. Once you're ready, paste your answers in the chat. This is again a bit of a tricky one, so I apologize for being particularly nasty today with the questions. But a lot of you actually getting the correct answer, which is a really great sign. So the answer here is actually B. A lot of you have switched between A and B, which is great. Remembering that C through E are all the diagnostic, like I think it's called Marsh's or Marshall, I can't remember. I think it's Marsh's criteria. Correct me if I'm wrong, anyone, but Marsh's criteria for there's like the biopsy results of celiac disease is those three things combined. So those are all probably going to be observed. TTG being positive is also most likely to be observed. A lot of you have said potentially if she's IgA deficient or IgA deplete, she might not be able to have as many TTGs there. Usually when you're ordering a TTG, you will also order a total IgA alongside it. There's no indication in the stem though that she has an IgA deficiency. The reason why B is correct is because it's saying HLA-DQ2 and HLA-DQ8 positive. HLA-DQ2 is the more common one. That's seen in like 90+% of patients. HLA-DQ8 is actually very rare. It's seen in maybe 5 or 10% of patients who have celiac disease. So the fact that you're having both of these being positive is extremely unlikely in a patient. If it only said HLA-DQ2 or it was either or, that would make more sense. So A is fine, C is fine, D is fine, E is fine. B is just much less likely to happen in the real world. Okay. And most of the time, you actually don't order these HLA tests unless you're concerned about a genetic component or if the patient specifically requests it. Most of the time, it's just A and a biopsy, and that's it. Hopefully that makes sense. Well done. Here's the next question. A 45-year-old male presents to the doctor with complaints of anal pain and discomfort during defecation. He also reports bright red blood on the toilet paper and in the toilet bowl after he has had a bowel movement. Physical exam shows swollen, bluish, and tender mass around the anus. So this is on a DRE. So what do you think the most likely diagnosis is? This is a mass. I've got a question. Is the mass inside or outside? I'll get to that. That's a good question. Most of us have picked D though, which is fantastic. So the answer here is D. And the reason why we're thinking it's D, yeah, exactly. So it's tender. And the kind of description of it being a swollen, bluish, tender mass is making you think this is like engorged veins. And so you're thinking hemorrhoids, especially with the frank bleeding with bowel movements. Differentiating between internal and external is a bit trickier. And generally, you'd be able to have a feel for it when you're doing an examination, and you'd be able to know whether it's like based on anatomical landmarks where you think it is. But the fact that it's painful is more characteristic of external hemorrhoids because of like the embryology and stuff and the innervation, like the somatic innervation versus the visceral innervation above the dentate line. If it's above, which is the internal hemorrhoids, you're less likely to have really extreme pain. It's more likely to be subtle, dull pain. Does that make sense? I hope that makes sense. It comes down to the embryology of it all. You might remember that from back in first or second year, but it's to do with external hemorrhoids being somatic innervation, and so you are more likely to have pain, and also more likely to feel them on physical exam. Well done. Here's the next one. We're back to gastro. Yay. 28-year-old female presents to the clinic with sudden onset nausea, vomiting, abdocramps, and watery diarrhea. She attended a potluck party 3 hours before where she ate a creamy pasta salad that had been left out at room temperature. Please don't do this. Not advised. On exam, her vital signs are stable. She appears uncomfortable but not really ill. And stool analysis shows leukocytes but no red blood cells. So which of the following is most likely to be the cause of her presentation? Again, whenever you're ready, please feel free to paste your answers in the chat. Fantastic. I'm getting rapid responses here. The answer here is definitely E. So this is Staph aureus. There's a few reasons for this. One, just a food source, creamy pasta salad, anything that has been left out, like a dairy thing, and that doesn't have, or it's been left out in room temperature and not properly stored, you're thinking about Staph aureus. That's just a beginning. But the fact that this was something that started very acutely, so it was only 3 hours ago that she had it. Generally speaking, with most of the other things or the other agents that are responsible for gastro, they develop after a bit of time. But because Staph aureus is releasing like a toxin, that actually happens very, very quickly. Within a few hours, you get that Staph aureus toxin acting and causing the diarrhea. So any situation in which you have a sudden onset of vomiting or diarrhea after ingestion of food, especially if it's something like this, it's more likely to be Staph aureus than anything else. Okay, well done. Okay, here's another one for gastro. These are more questions to test like your buzzwords. So if you're not familiar with these buzzwords, that's fine. Once you've seen them once, like you'll remember them for the rest of the questions if they do come up. So don't worry if this is all new language for you. Just take a note of some of these buzzwords. So you got a 45-year-old traveler, prolonged episodes of loose stools, lower abdo pain, and weight loss. Symptoms started 2 weeks ago from a tropical vacation, and microscopy of the stool shows trophozoites or trophozoites with engulfed erythrocytes and flask-shaped ulcers on colonoscopy. So which of the following do you think is the most likely organism? Again, feel free to post your answer in the chat. Even if they're guesses, that's totally fine. Just what you think is more likely. Yeah, good. I can see a lot of people going back to first principles and thinking about which of these is most likely. Like if you think about the term trophozoite, where that's coming from is that this is a parasite, right? This is one of the stages in its development. And so we're thinking this is a parasite. And that automatically rules out a few of the options here, especially D and E. We're not thinking those are the causes. The only real differentiator between A, B, and C is the actual description. So if you have trophozoites in the stool microscopy, that's already very, very solid for B, which is amoebiasis or entamoeba histolytica. And then additional to that, the engulfed erythrocytes and flask-shaped ulcers, they're mostly pathognomonic for that option as well. Generally speaking, in an exam though, it's the trophozoites by itself, which are enough for you to say this is amoebiasis or B. But I've added on the extra one so that you are also familiar with some extra buzzwords that may or may not come up. So they're not necessary, but they're just there to kind of complete the picture as a whole. And you've also got the tropical vacation, so it's less likely to be something super common. Do you mind going through the different organisms or linking something to read about them? Yeah, definitely. So after this, I've got a few like summary tables and stuff that go through organisms, some buzzwords and timeframes. And I can definitely send those over to you, post it on the Facebook group. And I'm sure the rest of the PS Platypus team probably has a lot of really useful resources for this. It's kind of like pneumonia, right? Like knowing the buzzwords for your atypical pneumonia, it's sort of the same. You don't need to know every single detail. And honestly, this organism, in the scale of things, very unlikely to come up. But just so you have it in the back of your mind, it's here as a question. Okay, but we'll send you those resources in the next few hours, hopefully. Well done. Here is the next question. You guys are doing really well so far, so keep it up. 65-year-old male, left lower quadrant abdo pain, fever, leukocytes, and there's some localized tenderness in the same area, but there's no guarding, and his vitals are normal except for being a bit febrile. CT scan shows a thick sigmoid colon wall with pericolic fat stranding and a small pericolonic fluid collection. So given the likely diagnosis, what is the most appropriate definitive therapy? First of all, so what do you think this patient has? And based on that, how severe is what they have? And then based on that, what do you think is the most appropriate management? Hey, well done. Very good. So we've identified that this is diverticulitis based on the location. Left lower quadrant is pretty good for diverticulitis, but also ulcerative colitis. Doesn't really fit the picture of ulcerative colitis, so we're thinking diverticulitis. That's good. It's also an elderly patient. They've got leukocytosis, all of that sort of fitting the picture. And you've got evidence of inflammation on the CT scan. So anything to do with like fat stranding, plus or minus some fluid around the organ in the abdomen, that's very that's going towards some sort of inflammation, no matter what organ it is. There's no evidence that this is a perforation or that this is a necrotic piece of bowel. So we can actually, most of the time, as someone has put in their answers, we can most of the time manage this quite conservatively. So all we need to do in this case is provide antibiotics and these are mostly prophylactic antibiotics to prevent infection, and also bowel rest to kind of remove the pressure on the bowel and prevent it from becoming worse over time. You wouldn't go straight to surgical resection because there's no evidence, as I said, of any damage to the bowel. And in this case, because it's it's an acute episode, you would not want to order a colonoscopy right now. So someone's asked why not see. You wouldn't want to order a colonoscopy now to assess whether there is any other bowel involvement. And generally, because you've done a CT scan, subduing someone to a colonoscopy as well doesn't really make sense, right? You've already got really good imaging. Colonoscopy is not going to add too much unless you wanted to get a biopsy or something like that, which is not indicated here. Okay, well done. So just remember, diverticulitis, most of the time, it can be managed supportively. Okay, so I don't think this is my question. Might be Deepak, if he's online. Or if not, James, you can take this question if you'd like.
This is my question, sorry.
Okay, fantastic.
I'm more than happy to. Right. What do you guys think the answer is? Getting a couple answers in. So yeah, underlying cause is the same thing as definitive management. So we just ask, what's going to solve the pathophysiology that's actually causing everything, rather than what you would do immediately. Because obviously, in a case like this, antiemetics, analgesia, that's all higher up in your list because you can give that right away. But the answers I've got through are C, which is good. Because can anyone tell me what they think this guy actually has? Something bleeding? Well, that's, yeah. If he's vomiting blood, probably should be bleeding. Somebody said gallbladder. Probably not, just because of the location of the pain, the nature of the pain, and the hematemesis usually isn't associated with gallbladder. But everyone is now telling me perforated peptic ulcer disease, which is absolutely correct. So basically when we're thinking about this history. The epigastric pain, that's a bit of a clue because it puts you in that stomach region. He vomiting blood again, so we're thinking something in the main gut line is probably a highest differential. So it could be something esophageal if we're thinking of hematemesis always. But he's in a bit of shock, so something's happening, and that sort of suggests a bigger bleed than we'd expect with just just like pure ulcer or something like that. So something's gone wrong. It's also a sudden onset thing, so something has happened. It's not like it's a slow developing thing. Epigastric, what does rebound tenderness tell us? That tells us that he has peritonitis. So it means that somebody has actually, something is actually perforated in this case, and that means that you're actually going to have inflammation of the whole cavity, which is where we get the rebound tenderness from. The epigastric guiding is because the pain is going to be most acute in that stomach region. So even though he has overall tenderness, he has some in that region. And that is useful for you in a peritonitis history because it helps you localize it. So if we're thinking epigastric, then we're thinking, okay, well, maybe he's got a duodenal or a peptic ulcer that has perforated. If he's got say midline pain, especially pain out of proportion is a really big buzzword for mesenteric ischemia. And so on and so forth. Hell, if he has, right lower quadrant pain that has then now become generalized, then maybe we're thinking of a ruptured appendicitis. So lots of different differentials that can give you some ideas. The ABG and coagulation studies are also a bit of a clue there to tell you that this probably isn't something like mesenteric ischemia. So the fact that he's stable in that regard means that that's probably not the issue. Somebody asked a good question, which is why the shoulders tip pain, and also why I put a little hint there about the pending chest X-ray. So if we have a perforated abdominal viscera, specifically with the actual tract, so stomach, your bowel, then we're thinking, okay, well, that's open to the outside, so air gets in there, and especially with the stomach, because it has less sphincters involved, and there's going to be some air there. If you get a perforated pelvic ulcer, one of the best signs you can see of that is air under the diaphragm. So if you get this back and you get your chest X-ray and you see, okay, well, there's some air that's collected under the diaphragm, and then maybe there's a big fat hole in the stomach, then that gives you a pretty good clue as to what's going on. So the shoulder tip pain is as a result of involvement of the phrenic nerve. Because we've got that pushing on the diaphragm. Yeah, so it's referred pain. It's not, he hasn't just got something else going on in his shoulder. Good stuff.
All good questions, guys. Here's the next one. Another abdominal X-ray for you. So intermittent central abdominal pain, obstipation, which is just constipation and also inability to pass gas. On exam, his abdomen is distended with tinkling bowel sounds. So we're already thinking along the lines of a certain sort of condition. An abdominal X-ray is performed. What do we think is happening? So again, whenever you're ready, after you've had a good look at the X-ray, paste your answers in the chat. Brilliant. Well done. So the answer here is definitely E. So this is a sigmoid volvulus. Can someone tell me what is the name of the sign that we're looking at here? Before it was the bird beak sign. This is coffee bean sign. So here's a picture of what that looks like. Admittedly, it's on the wrong sort of side in this case, but essentially what you're seeing is kind of this like circle, right? Like this circle, and then you've got this sort of middle line that looks a bit like a coffee bean. And that's pretty good for us thinking this is a sigmoid volvulus, which is involvement of the large bowel, hence why it's not D. So we're definitely thinking it's bowel obstruction just based off the picture, but the question is what's causing it? Anything could cause a bowel obstruction, whether it's inside the lumen, whether it's in the wall of the bowel, or whether it's outside, something compressing it. But this kind of shows us, first of all, it's pretty bad. And secondly, it's more likely to be a volvulus than any of the other things that we're worried about. So keeping that in the back of your mind, this is a sigmoid volvulus leading to a bowel obstruction. What do we think is the most appropriate first-line therapy for this patient? So you can think, how bad is this patient's presentation? Admittedly, I haven't given a huge amount in terms of how stable they are, that sort of thing. But just have a think. What do you think, with this amount of information given to you, would be the best thing to start with? Well done. So most of you are going with A, which is great. This generally is going to be the first thing you do for any patient who doesn't have evidence of a perforation and has evidence of a bowel obstruction. It's called the drip and suck method. So drip being IV fluids to kind of rehydrate them, and suck being for decompression of the bowel via a nasogastric tube. And that's the general formula you start off with for any bowel obstruction, where you're not worried about imminent death. If there was evidence in the stem of them saying hemodynamically unstable or losing consciousness or that sort of thing, then you might be going more towards C. But in this case, you're more likely to just go with A as your definitive first line therapy, and then work your way up and see how bad is this going to get, whether I need to book in a theater or whether I've solved everything and I can do another another abdominal X-ray and see if it's resolved the volvulus. Or potentially what caused the volvulus in the first place? Was it adhesions? Do I need to fix those? That sort of thing. But first line, it's always drip and suck. And that's ideally what you should say to start off with when you're doing your OSCEs or anything like that. Cool, brilliant. So it's a sigmoid volvulus, but you're thinking about bowel obstruction overall for your management. Here's another similar sort of thing. So we've got two patients. They are admitted to your hospital at the same time. They've got abdominal pain, nausea, and again, new onset constipation. And both of them have their radiographs or abdominal x-rays done, and they're shown there. So I know it's a bit of a double whammy sort of question, but I want you to think what sort of bowel obstructions are demonstrated here, if any. So remember the options here are between small and large. I want you to think about what helps you differentiate, like anatomically speaking, what helps you differentiate small bowel from large bowel. All right, I'm getting a lot of mixed responses for this one, which is fantastic. The answer here is actually, it hasn't, okay, so someone has now said this is the answer, which is great. The answer here is C. It's actually both small bowel obstructions. And I want to quickly go through just the anatomy and how to differentiate them. Remember that the small bowel has those like circles that go around the whole of the bowel called the plicae circularis. And you can actually see that in both of the images here. You can see it much more better on the left-hand side radiograph, but you can also see it on the right-hand side radiograph as well. And there's another feature here which points you more towards small bowel as well, but I'll go through that in a second. Large bowel generally has the haustra, and those don't go around the whole of the bowel. So it's less likely to be large bowel in these two cases. What the right side has, which the left side doesn't, is these air fluid levels, which you can see all throughout. Some people call it like the string of pearls sign or something like that, but it's essentially just air fluid levels. Does anyone want to guess why they think this patient or the one on the right has air fluid levels and the patient on the left doesn't seem to have those? Why might one have it and one not have it? Yeah, brilliant. Well done. Good thinking. So the one on the right is more likely to be standing up. When they're standing up, you're more likely to see those air fluid levels. And it doesn't help that it says patient standing at the bottom, but it's a really, really good reason for that happening. Same with when James was talking about the chest x-rays to look for pneumoperitoneum. It's much more useful if they're standing up, because then you can see the air kind of going upwards. Similar thing is happening here. So it doesn't mean that, the left-sided patient doesn't have air fluid levels, therefore it's not a small bowel obstruction. It's still a small bowel obstruction. It's just more likely that they're so unstable that they're not able to stand up for the x-ray. Okay?
And
it's a
I
bit of a
just
trick.
I just want to shout a really good catch in the chat, which is that the film on the right is a PEDS patient.
True.
Is that a PEDS patient on the right? Look at that pelvis. That is a non-infused pelvis. So good catch. And you can also tell by the shape of the abdomen. Now, it could be a guy with, there could be, extreme distension due to the obstruction. But yeah, no, looks like a PEDS patient to me.
Well done. Yeah, so oftentimes when you're doing, when you're looking at an abdominal x-ray, sometimes you might have to supplement it with a chest x-ray if you're worried about air being under the diaphragm. In kids, there's really almost no such thing as just like an abdominal x-ray. because you generally get to see a bit of the chest as well. So it's actually a lot easier because of how small their bodies are. That's a really good catch. This is a pediatric patient. Poor thing. All right. So someone's asked me why is the one on the right a small bowel? It doesn't even seem to have the circular. If you actually try and follow, like just pick any of the lines, like yes, up here somewhere, you might not be able to see as many of the lines, but if you try and pick a line somewhere across here, you can see it goes along the diameter of it. If you try and compare that to a large bowel, you will notice that they usually don't have it going even like midway into the bowel wall, which is very indicative that this is a large bowel. Also, the location more central than it being peripheral. And finally, the air fluid levels, you generally don't see that at all in large bowel obstructions. You only really see them in small bowel obstructions. Okay, cool. Next question. This is not mine, I don't think.
This is one of mine.
Awesome. Have a go.
Yeah. Okie dokie. Just send your answers through now. We have them. I've only got one so far. Oh,
I've got one, which is E.
okay. All right. I've got a couple people who are unsure. I think I've been mean with this one. Okay. No, that's good. That means we're learning things. So let's look at this guy's history. So we've got history of diarrhea. We've got a Frank Blood. So right from the start, Frank Blood is telling us that we've got some problem to at the end of the bowel. So it doesn't rule out too many diseases. Like something like Crohn's could still present with Frank Blood if you have a skip lesion right near the end, but it doesn't rule in anything either. So we get a negative stool culture, or probably not an infective cause. We get a mild uveitis, which is interesting. It's very systemic for what we're thinking about. We get some blood streaking, but no other abnormalities. Now, the DRE is sort of important. I don't know if you can necessarily rule out hemorrhoids on DRE, but it certainly lowers your clinical suspicion of them quite heavily. And the fact that we've got this sort of 6-week history also is not. It could be a progressive history of hemorrhoids that are now becoming symptomatic, but it's not great. So in absence of any findings on DRE, probably the highest sort of suspicion we have is for IBD of some sort. Now, again, it could be Crohn's, but the fact that we've got some very sort of back of the tract symptoms is probably leading us a little bit more towards UC. Now, the way we find out is by doing that colonoscopy, but we don't know that yet. So, assuming we do have UC, we need to think about what we're going to do about it. Now, you're not usually going to just resect somebody's colon because they have ulcerative colitis, because that's not going to really solve the issue. Your rubber band ligation is for hemorrhoids, so that's a distractor, which I'm glad nobody fell for. Topical corticosteroids also for hemorrhoids, can use it for other stuff as well, like fissures. So really, the two choices that people went for are sulfasalazine and infliximab. Now that's good because both of them do work for ulcerative colitis. So neither of them is an ineffective treatment. However, first-line management is not always guided by what worked. It's guided by what do we think is appropriate to use first. And although you may hear about infliximab and it's very exciting, it's very cool, it's not the first-line treatment. So sulfasalazine and other 5-ASA drugs are going to be our first-line treatment for UC. So this guy's probably going to go on sulfasalazine. He might fail, go to mesasalazine, but only afterwards is he going to go to infliximab. So your first line is not that for the first presentation of UC.
All right, well done. Next question.
So somebody asked the question, is there a difference between induction and remission in terms of drug choice, generally for IBD? I haven't reviewed my Crohn's too recently, but I do remember having a look at some guidelines for for UC. So the general shape of things for UC, as far as I'm aware, and Jen, feel free to chime in if you have additional data, but you would use, again, your foundation of treatment is your 5-ASA, so sulfasalazine and the like. If you then have, like, if that's not enough to treat it, you can look at so corticosteroids, and that's usually orals. I believe you can give IV as well for flares. And then you can think of, again, the biologics like infliximab. In terms of non-active disease, so just maintenance therapy, usually you drop them back to 5-ASAs. I haven't heard of corticosteroids be used as maintenance therapy because, as you guys know, there are many consequences to long-term steroid use. So I think you'd probably want to go with either a 5-ASA or a biologic, so infliximab, if that's indicated. But yeah, whoever said they've seen steroids be used in flares, absolutely correct. Yeah, you can do that. Right, and have a look at this one. So this is a follow-on, same patient, UC fellow, and he's now got some different symptoms.
Someone's messaged me with E.
Interesting. I'm getting quite a few different answers, although usually grouped in the same sort of area. If anyone else is sitting an answer, feel free to send it through now, and then I'll talk about what's going on. Okie dokie. So we have a couple different ideas here. Now, we've got basically a cholestatic picture on the LFTs. That's probably the biggest foundation we can look at here. Icterus, mild jaundice, like everything's pointing to we have some form of cholestasis. So something is up with our bile ducts. Okay. The question is, what's up with our bile ducts? So a couple of people have gone for antibiotics, which sort of suggests to me that maybe you guys are thinking of cholangitis or hepatitis, which is not the worst guess, but probably not our best differential here, considering that he has UC, because UC is a really big risk factor for a particular type of bile duct issue, which is your primary sclerosing cholangitis. Okay, so that's what we're going for as our main differential here. Now, with that in mind, we have to think about what we can do about it. Now, you guys may have heard about ERCP with stenting for PSC. Now, that is a maintenance therapy, or sort of a buying time therapy. It does not treat the underlying cause. We have no treatment for PSC overall. So the correct answer here is A, actually, that the underlying disease process is irreversible. However, it is useful for you guys to know that if you do ERCP and you give someone a stent, then you can stave off their symptoms. So you can give people symptomatic treatment, but you can't treat the underlying cause in this case.
Yeah, unfortunately, because of the nature of this disease, the actual sort of only definitive management is a liver transplant. And you don't need to go to that stage when you can manage it in other ways. So yeah, really good question. All right. This is a really quick one. You don't have to read the stem. It's essentially asking about PPIs. And the question is, what is the most likely adverse effect that you would tell this patient? Just have a quick read and let me know what you think. It's a slightly elderly gentleman that we're talking about here. I've got a few people saying A. I think you may be thinking about ACE inhibitors. That's more likely to present with a dry cough. Also, in people with GORD, they can have a dry cough. That's true. But this is more asking about the adverse effects of the medication. Yeah, fantastic. So most people have put down D, which is correct. I'm glad no one fell for C. Um, Gynecomastia, there's a few case studies and a few case reports of a lot of medications causing that. And you may be familiar with some diuretics and things like that, which are responsible for causing gynecomastia. But for the most part, iron deficiency, the reason why that happens is because, yeah, exactly. So iron is absorbed in the duodenum. And so if you're affecting the way that those acids and stuff are being produced, you're going to affect the way that iron is absorbed. And this is really, really important, especially in the elderly who are already not getting enough iron and who already have problems with absorption at a baseline. It's really important to not necessarily preempt it, but just to warn them and to warn them about any symptoms that they might get. And if they do develop them, you can come back for iron replacement. So in this case, D is the correct answer, and it's to do with gastric secretions being reduced. All right, for this one, again, you don't, just to save time, don't need to read the whole stem. Just know that this is a patient that is in the hospital for pneumonia. 7 days since her admission, the registrar is doing the rounds, and they notice that they have crampy abdo pain and watery diarrhea. She also had pseudomembranous colitis last month while she was in the hospital, and it was treated pretty well with Metro. So what do you think is the best medication for her now, given what you think she most likely has?
I want to drop in really quickly, by the way, while we're answering this one. So some people ask me, why can't the previous one be choledocholithiasis or acute cholangitis? Probably the biggest thing, and to be fair, I think it is a bit of my bad that I didn't give it a longer disease course, which would have made it more clear that it's likely to be PSC. But he's not really in an infective state. He's not febrile. He hasn't come in with any fever, any nut chills, anything like that. And so it doesn't really look like that picture. So in terms of like our diagnostic criteria for acute cholangitis, we're thinking, so a classic Charcot's triad. So jaundice he does have, or abdominal pain he does have, but he doesn't have fever, which we would really expect in an infective cause.
Awesome. Yeah, so for this question in particular, I'm getting a few answers already alongside explanations, which is fantastic. So it's always good to be able to justify why you've put down an answer. In this case, we know that they probably have pseudomembranous colitis again. So that's like based on the fact that they're already in the hospital for pneumonia, they're probably on some pretty strong antibiotics, and their clinical picture fits with it. We might still want to do stool antigen or stool tests and that sort of thing, but for the most part, we're thinking pseudomembranous colitis again. Now, the fact that they've already been treated before with Metro means we can't use it again. And if you look at the ETG guidelines, you'll see that there's actually like sort of a step up process for how to treat these sorts of things. So first time you can treat with Metro. Second time, you're worried that there might be like a resistant strain or a resistant problem leading to this person being more susceptible to having those infections. So you actually will treat with oral vancomycin. It's actually very, very uncommon to see oral vancomycin prescribed. Most of the time it's IV vancomycin because it's quite broad coverage and broad spectrum. So it's often used, especially in the cases of resistant staphs or even in cases of sepsis. In this case, oral is the way to go because it's going to go straight to the gut and have an impact where it needs to be, rather than just being in the systemic circulation where it's not going to do much. D, which is IV fidaxomicin, that's another medication. You don't have to worry about it too much, but essentially, if it happens a few more times, maybe 2 or 3 times, that's the medication that you often will go for. I can't remember if it's oral or IV. It might be IV because I put the option there, or it might be oral. Just if someone wants to check up on that, they can. I think it might be oral. But in this case, because it's only the second time, oral vancomycin is fine. Okay. Cool. Well done. Here's another one. A bit of so this is gastro again, high grade fevers, headaches, diarrhea. He recently traveled to a place that had poor sanitation and hygiene. They've got splenomegaly, which is not actually really evident in this diagram, but just assume they have splenomegaly, and they've also got a rash. The first time I looked at this image, I could not see the rash, but I will just highlight to you these sort of red bits on his chest and on the tummy in a few spots. So what do you think is the cause of this presentation? Yeah, brilliant. Well done. So I think a lot of you are familiar with some of these more niche buzzwords. In a patient that has traveled from overseas with fevers, plus gastro symptoms, plus or minus splenomegaly, and often with these things called rose spots on the chest and tummy, you're more likely to think that this is Salmonella typhi than anything else. And that's just because of the constellation of those things. So even like oftentimes in the exam, they won't really give you a picture because it's sometimes pretty hard to tell. They'll just say rose spots, and then you're thinking, okay, Salmonella. I can't think of an easy way to remember it, but I guess once you've seen it a few times, it'll become easier to remember. So well done. Here is another question. I'll let you have a read of this one. James, was this your question? Do you remember writing this one?
This is one of mine, yes. Take it.
Okay, fantastic. We're almost at the end, guys. So just keep going as you are. You're doing such a good job. Also, I've
Okay,
had
what are
two
we
people
thinking?
message me saying C.
Yeah. Okay, I've got a couple for C as well. Yep. So we've got a history of C. Azaria, so something's going on inside there. Several month history, so we're already ruling out acute causes. So we're thinking, okay, what's the chronic condition that will get us that? Progressive weight loss, anemia. I mean, it could be celiacs at that point. Not super likely, but we're still got a bit of diagnostic uncertainty. Small ulcer in the mouth. Like, if we want to really stretch it, we can say, okay, maybe it's an iron deficiency, but really most likely is that's an aphthous ulcer, and this is Crohn's disease. And so that's our most likely differential C. So yeah, well done.
Great. Well done, everyone. Here's the next one. Again, I would don't read the whole thing. I just want to say is a patient who had rheumatoid arthritis. They've had blood in their vomits, intense abdo pain that they usually get that's better when they eat food. You order an endoscopic investigation and you identify bleeding ulcer in the posterior wall of the duodenum. This is a bit of anatomy. It's more clinically relevant anatomy. So I'm not trying to be super mean, but just knowing sort of what the major arteries that can be affected can help with surgical interventions, essentially, is what I'm trying to get at here. And you all are already jumping to the gun, which is fantastic. The answer here is B. And yes, this probably was a question in last year's exam. So the fact that you guys remember it still is a really, really good sign. The gastroduodenal artery kind of goes behind the posterior part of the duodenum. As the name suggests, it's like really easy to remember because it has duodenum in it. The other arteries are not as affected. I think the right or the left gastric artery is more affected if you have an ulcer in one of the curvatures of the stomach, but that's not as important because more often than not, a bleeding stomach ulcer is going to be a duodenal ulcer most of the time. Cool, well done. Yeah, here we go. So we've got a 37-year-old who presents to the clinic with mild abdo discomfort and yellowing in the white of the eyes. His urine is also much darker than usual, and he's worried because he's got a lot of nausea and weight loss. On exam, there is a palpable mass in the right upper quadrant of the tummy, although there are no overlying skin changes and the lump itself is not tender. So given the most likely diagnosis, which of the following is the most specific at diagnosing this patient? Yeah, brilliant. Well done. So no tricks here. Although I did try and put a few things that might overall still be relevant for this patient's management. The most specific test will always be biopsy. If you're worried in this case about a pancreatic cancer, which is the painless jaundice, there's a bit of discomfort that it's not really pain, right? You've got painless jaundice and you've also got a palpable mass. So that's more along the lines of a pancreatic cancer. CA19-9 is one of those like tumor markers that you can test for, certainly. And there are a lot of other tumor markers that are probably more likely to be used. And you'll learn about, for example, CA125, which is used in ovarian cancer. It's more commonly used. In pancreatic cancer, CA19-9 is more of an academic thing. It's not really tested for a huge amount. Sometimes it is taken to monitor for disease progression and treatment response. But most of the time, especially if it's a first diagnosis, you won't take this just for no reason, even if it has a correlation with pancreatic cancer. So for those of you who pick B, you're thinking along the right track. But in terms of what would be the best for this patient, you need to get tissue and to be able to do an analysis of that to confirm it. Well done. Here is another one, which I don't think is mine. Maybe James?
I didn't. No, it is. It is.
Yes, nice.
There
Okay,
we go.
cool. Also, someone has just popped in the chat. It is also linked with biliary tumors. So absolutely, it's not very specific.
I got a couple of people answering E. Feel free to send through your answer if you guys are also thinking of anything. But yeah, no, correct. The correct answer is anal fissure. I put this on because it's an Alfred favorite. If any of you guys are there, they absolutely love putting these on this anoscopy for some reason. But yeah, so really, like we're thinking of okay, so like perianal symptoms. We've got a 2-day history. We're probably not thinking about a fistula or an abscess or something like that. That's pretty quick. There's no constitutional symptoms, which is also, especially with an abscess, we might expect to see some of those. Our two top differentials really for, it hurts when I poo are going to be things like hemorrhoids and anal fissures. And really, the fact that it's hurting means we're already choosing between external hemorrhoids and anal fissures. So, probably the biggest demographic factor that is separating between those two is age. So a 24-year-old, you're going to have a much, much lower clinical suspicion of hemorrhoids than in, a 45-year-old or a 60-year-old or something. And so if those older people come in, you're like, yeah, you probably do have hemorrhoids. But with a so the fact that it's severe pain also, so hemorrhoids is more of a progressive thing. If she's only got pain for the last 2 days, then either especially in severe pain, either her hemorrhoids have bulked up massively over 2 days, or she's got an anal fissure. So the acute severe history in a young patient is very suggestive of anal fissure versus external hemorrhoids. If it's a slow developing history in an older patient, then you may be thinking more hemorrhoids. But ultimately, you do a DRE or you do an anal examination and you'll find out.
Fantastic. Here is another question which I haven't written.
Yep, so this one's mine. Hey guys, nice to meet you all.
Return of the King.
So 3 more questions till the end. Last 3, don't take them. Don't be too stressed if you don't get them because they're a little bit tricky. I sort of put them in because they were ones that tripped me up, that I wasn't too sure of. Yep, so getting a B. And that is, yep, getting more B's. Cool, that's correct. Nice. Good work, guys. So in this case, with progressive weakness and numbness of the lower legs in a relatively acute few-day setting is very indicative of Guillain-Barré, and that is classically triggered by a recent viral illness. Oh, not viral, but recent illness, in particular Campylobacter gastro. You can note that there is leg weakness as well as sensory loss as well as muscle weakness, which is pretty typical. Yeah, nice. Okay, have a go at this one. All right. Nice, good thought. I'm getting a D. A few more guesses would be good.
I had a few people message me with A.
Okay. uh,
I promise that's not just me making it up, so that we get more right answers. This is legit.
Jadam's covering all for you guys because it is going to be A as the answer. So in this case, we have someone with a history of alcoholic liver cirrhosis brought in by ambulance with what is probably going to be some sort of ketoacidosis, since ketones are found in the urinalysis and there's a metabolic acidosis as seen in the ABG. The main thing to know is that alcoholic ketoacidosis is something that can happen. So typically there's periods of starvation or like malnourishment after an alcohol binge, which leads to it's a bit strange, but it is euglycemic as opposed to euglycemic meaning not hypo or hyper, as opposed to the hyperglycemia you see in DKA. In this case, ketones are formed to sort of supplement nutrition, as similarly in DKA. The answer is going to be thiamine because people with a history of alcohol are notoriously deficient in thiamine, which is pretty bad because it can lead to two big problems, which is Wernicke's encephalopathy and Korsakoff syndrome. Both are, especially Wernicke is, I think, happens first, with Korsakoff being a little bit more severe. But to prevent that, you want to supplement thiamine, and saline is also done. It's a bit of a tricky question. Hydrocortisone, you're thinking, that's done more so in something like Addison's. Insulin plus potassium and other electrolytes are done in DKA. And the other two are sort of options that would throw you off. This is also like, when I say first line, these are like the two main components, but certainly there's going to be other electrolyte derangement that you want to correct. So this isn't like the proper answer of thiamine and saline, but these two are the key components that you want to administer quickly, especially thiamine.
Brilliant. Here's the last question, guys. And on a strong note, you got this.
I just got a question of why giving saline. That's a good question. I'm not like exactly sure in the pathophysiological sense. My guess would be that given there's vomiting and they're likely going to be fluid replete or deplete, is my guess.
From what I'm aware, I think that's the reason as well.
Yeah.
Cool. 2 brain cells. Let's go. Okay. Okay. Yeah. Have a go at the last one.
Okay. This was a little bit troll. Don't stress too much. What
I
do you guys
got
think?
2 E's in
2 E's.
my direct messages.
Oh my god. Any more E's? Can someone DM me E? Yeah, I got an E. Okay, the answer is E. Thanks, guys. Yeah, so the concept is that you'd really don't want to be putting anyone on a PPI long term. Oh, I just got a question. Could it technically be C long term because your body compensates by producing more acid? I think I'm not too
Does that
sure.
happen?
I don't know if that
I
was the
actually have never
phenomenon,
heard of
honestly.
that.
I imagine if you would discontinue it, then it would cause the problem rather than it being a complication of you still on it, maybe? I don't know. Classically, we're taught fractures. You end up with some electrolyte derangement due to basically not enough acid, so it messes with your digestion. There are specific like pathophysiological mechanisms, like I think calcium, there's something to do with oxalate as well, where it's too tightly bound for it to be digested because there's not enough acid. and you end up with weaker, like osteoporosis essentially, and there's an increased risk of fractures. You also have hypomagnesemia and hyponatremia, but those aren't options here. So fractures is the main thing to be worried about.
Brilliant.
Cool.
And also, just to answer that previous thing, I don't think it's actually very common to develop PPI resistance with chronic use. It's more like you will already be resistant to PPIs, and that's when it's classified as resistant reflux, and then you have to go on to other medications. So in terms of the balance of probabilities, what Deepak has said is more common.
Yeah. Thanks, Jonah. That's all the questions that I think we
I think
have
that's it.
for y'all.
That is all. Sorry we just beat the buzzer. We're just 1 minute to 8 o'clock. So you can't say we went for 2 hours. We went for 1 hour and 59 minutes. But thank you so much for sticking around, guys. Well done on the questions. Best of luck for your placements, and we'll see you at the next one. If anyone has any questions, please feel free to stick around with us. Or not.
Nice, great work.
Absolutely.
Good job, guys.